Welcome to the deep dive. Today, we're doing something a bit different. Not just hitting the books or lecture notes. No, definitely not. We're actually going deep into root canal treatment. Yeah, and specifically, we're looking at those common mistakes, the ones that can, genuinely ruin the whole case. Or even worse, actually cause the loss of the tooth itself. That's really the focus here. And our mission for this deep dive is really to zero in on those critical slip-ups, especially the ones that happen right at the start. That's right. It's pretty fascinating how a tiny error, something seemingly small in the first few steps, can just cascade. Totally. It can turn what should be straightforward into, well, a complete nightmare. Exactly. So for this session, we're concentrating on access cavity and instrumentation mishaps. Yeah, the very beginning. Think about it like laying the foundation for a house. Right. If that foundation's off, the whole thing is shaky, potentially compromised. It's really crucial, these early steps, and surprisingly easy to get wrong sometimes. It really is, and we set this up for you listening. Maybe you're a dental student just getting the hang of things, or a trainee in the clinic wanting to sharpen your skills. Or, even if you just enjoy sort of analyzing cases, thinking like a detective about what went wrong.
Let's dive into the first major category of endodontic errors, access cavity mishaps. Now, the access cavity is literally your gateway into the root canal system. If it's not done correctly, you're setting yourself up for a chain of complications. Let's go through the most common mishaps in this step. 1. Missed canals. Explanation. Sometimes, even though you've opened the pulp chamber correctly, you might completely miss one or more canals. This happens a lot with maxillary molars, especially the MB2 canal. Example, a case with upper first molar. Patient still experiences pain post-treatment. Retreatment reveals untreated MB2 canal. How to detect. Post-op radiographs showing radiolucency despite treatment. Clinical signs of persistent symptoms. How to prevent. Use CBCT in complex cases. Always map the floor of the chamber carefully using DG16 Explorer. Look for symmetry and color differences in the pulpal floor. How to manage. Retreatment if necessary. Locate and treat the missed canal using magnification and ultrasonic tips. 2. Perforation during access preparation. Explanation. This happens when your burr accidentally goes too deep or laterally outside the correct path, causing a hole in the tooth structure, usually in the floor or wall. Example, patient with mandibular molar, large mesial perforation due to aggressive access without depth control. How to detect. Sudden bleeding not consistent with pulp tissue. Drop-in feel with the burr. Radiographs showing off-path burr angulation. How to prevent. Always evaluate pre-op radiographs. Know the average depth of pulp chambers. Use endo Z burrs and keep parallel to the long axis. How to manage. Immediate sealing with MTA or bioceramics. In severe cases, surgical repair may be required. 3. Inadequate access. Not enough tooth structure is removed, leading to straight line access issues. This causes instrument stress and inefficient cleaning. Example, case where files kept binding and eventually fractured due to curved access path. Detection. Clinical difficulty inserting files. Radiographs showing deviated file paths. Prevention. Enlarge access cavity adequately to allow direct canal entry. Check using a mirror for straight line vision. Management. Modify the access shape. Replace coronal restorations if needed. 4. Overextended access. Removing too much tooth structure, especially paracervical dentin, weakens the tooth and increases fracture risk. Example, a premolar fracture vertically 6 months post-op due to overly aggressive access. Detection, large flared chamber seen in radiographs. Thin remaining walls clinically. Prevention, follow minimally invasive endodontics protocols. Use round burrs carefully. Management, consider cuspal coverage restorations. Reinforce with fiber posts if needed.
5. Accessing the wrong tooth. Explanation, yes, it happens, especially with poor documentation or referred cases. Example, Tooth House 46 opened instead of House 47. Patient reports pain still persists. Detection. Clinical symptoms not matching treated tooth. Radiograph mismatch. Prevention. Triple check the referral and radiographs. Communicate clearly with patient and assistant. Management. Treat the correct tooth. Restore the mistakenly accessed tooth if it's vital. 6. Failure to remove all pulp tissue. Explanation. Incomplete deroofing or missed pulp horns leaves necrotic tissue that may lead to persistent inflammation or access. Example. Upper canine. Patient develops swelling weeks later. Lingual pulp horn wasn't removed. Detection. Lingering odor, bleeding, or pain after access. Clinical inspection shows chamber remnants. Prevention. Use a dye or methylene blue to visualize pulp horns. Check under magnification. Management. Re-access and clean chamber completely. Irrigate thoroughly and place proper medicament.
That wraps up part 1. Hit pause, grab a 10-minute break, and let your brain recharge. Don't forget to like and subscribe. Part 2 is even more exciting, and I'll be waiting for you right after the break.
Instrumentation mishaps. Once you've got good access, the next battlefield is instrumentation, shaping and cleaning the canal. And trust me, this step is filled with potential traps. Let's break down the most frequent issues. Diamond number 1, ledge formation. Explanation. Occurs when a file creates a false path by cutting into the canal wall, usually in curved canals. Example. Mesial root of mandibular molar, file unable to go past a certain point due to ledge. Detection. File stops short of working length. Radiographs show deviation from original canal path. Prevention. Use pre-curved stainless steel files. Glide path creation is essential before rotary use. Management. Try bypassing with a small K file. Use chelating agents and gentle watch winding motion. Diamond number 2, transportation. Explanation. When files straighten the canal and shift the original pathway, this may lead to weakening or even perforation. Example. Upper molar palatal canal over-enlarged on outer curve. Detection. Canal appears eccentric in radiographs. Blockage or bleeding during instrumentation. Prevention. Use flexible NiTi instruments. Respect original canal anatomy. Management. Fill with flowable bioceramics. Modify obturation techniques accordingly. Diamond number 3, zipping and elbow formation. Explanation. Occurs in curved canals when over-instrumented at the apex, creating a zip shape, often with a secondary ledge, elbow. Example. Radiograph showing an apical foramen shifted laterally. Detection. Sudden drop in working length. Difficult obturation. Management. Apical plug technique or surgery if severe. 4. File separation. Instrument fracture. Explanation. File breaks inside the canal, especially if reused, overstressed, or due to cyclic fatigue. Example. Fractured NiTi rotary in apical third of MB root. Detection. Sudden stop during filing. Confirm on radiograph. Prevention. Use single-use protocols, lubrication and proper glide path. Management. Attempt retrieval with ultrasonic tips. If not possible, bypass or obturate to fractured segment. 5. Apical blockage. Explanation. Pulp tissue, dentin debris, or broken file block the apex. Example. Increased resistance during instrumentation. Radiograph shows sudden halt at mid-canal. Detection. Working length changes. Irrigation doesn't flow freely. Prevention. Irrigate frequently. Use patency file regularly. Management. Re-establish path with small K files. Chelation may help.
Apical perforation. Definition. Breach of apical foramen, often from over-instrumentation. Example. File extends 2 millimeters beyond apex, causing pain. Detection: bleeding, unusual readings, X-ray confirmation. Prevention: use apex locator and confirm with radiographs. Management: seal with MTA and monitor healing. So that brings us to the end of our first lecture on Endo Mishaps. I really hope you enjoyed it and found it helpful. This is just the beginning. There's so much more coming your way in the next episodes. See you next time on Dr. Dentic. And until then, keep learning and keep drilling.